So before lunch break, Mickey Tripathi sort of set the table for this conversation by pointing to sort of two facts that I think are kind of interesting in the whole EHR space. One is that the vast majority of the $28 billion is earmarked in the ARA program for direct compensation to physicians, and then he also mentioned that 65% of healthcare is provided by practices of less than 4 physicians. And I think this is really important because we live in this environment here in the Boston area where we're sort of overwhelmed with these large institutions that are very sophisticated and have a lot of IT support and a lot of investment capital. They have the ability to innovate. They have innovation officers who go around the organization looking for opportunities to invest in emerging technologies. And this is what we see on a daily basis. But when you get west of Worcester or outside of the Boston area, you start to see that these are small businesses that are sort of struggling with all these mandates, incentives, and penalties to provide, an incredibly high quality of service to their patients. So, I think that sort of sets the stage. And then if you overlay the fact that there are 350 plus viable EHR companies out there in the world, and these guys are being sort of dragged kicking and screaming into interoperability in one way or another by the federal standards and by the need to stay relevant in the marketplace by adopting these standards, to the letter, being certified by NIST in order to, stay commercially viable. You have a very interesting situation where they're all implementing these things in proprietary manners currently, and I think Mickey also pointed to the fact that a lot of these standards, when they're run against these standardized tests, are failing for a variety of reasons, and so people are using workarounds, and as the various EHR companies start to iterate on all these different new standards, they're going to run into all sorts of complex incompatibilities, et cetera, that get in the way of true interoperability. So anyway, on the other hand, we have, in the world of our personal computers and our iPads and our iPhones, we have a whole innovative environment of social health sites that are very popular among patients and people who are interested in wellness. And so what we want to do in this panel, and I hope you find this really interesting, is sort of Ray's going to cover the recently announced stage 2 of meaningful use, because we know that the first stage of meaningful use was about putting physicians in front of screens. The second one is to connect those up in some sort of interesting ways, and then the third phase, essentially for the federal government, is to start using the analytics from this in order to improve healthcare outcomes and reduce costs, control costs. So, and then Stephen is going to look at it more from the social media point of view and how this data can become relevant to the healthcare experience for the patient. And then maybe we can have a conversation, maybe with your participation, in how we can bring these together and where these two might potentially meet or overlap or collaborate with each other. So I don't know, Stephen, do you want to start, or would you prefer that?
Sure.
Okay.
I guess first and foremost, I'll put sort of the caveat on all of my commentary that I don't think I've been invited here because of my exquisite knowledge of meaningful use and actually EHR interoperability at all. I've actually come from the patient angle. First started off building social networks for the purpose of capturing data from very rare illness communities and basically using this data and integrating it into the medical system. The types of uses of our data were basically profiling patients for clinical trials and trying to facilitate more rapid clinical trial recruitment. And then we started to move into this space of doing sort of passive observational research. And one thing that really struck us, we didn't really have any business model set up, and we actually found recruiting patients for clinical trials weren't actually that scalable. But what we found was that we learned so much about treatments in the real world and how people were maybe sort of tweaking the way in which they were using treatments that you just wouldn't learn in the in-clinic environment. And so when you sort of look at EHRs, for example, that's essentially where a patient would generate data in one environment, the clinic. But frankly, the patient lives out of the clinic so much, and what we sort of have come up with at D-Metrics is trying to figure out ways in which we can bring together all of this data which exists out of clinic, and whether it's on a mobile app, whether it's on an open social network, a forum, whether it's ePro or previously conducted research at some different outfit which doesn't live or reside within the clinical environment, and bring that together and try and see, can we learn anything? And we've gone through some struggles, actually, from various different stakeholders in the medical community who sort of say, patients don't know anything. Especially, you have the odd physician who says, I'm the gatekeeper of all of this knowledge. And so the challenge that we've had to overcome is really sort of making this data robust, quantitative, and actually far surpassing the amount of subjects that you'd find in a traditional clinical trial. So instead of looking at, maybe 1,000 patients in a survey, we look at 50,000 and start to look at their experiences with treatments and sort of cut up the patient base in certain ways. And we've actually managed to sort of really help. I feel bad coming here and saying the people we sell data to as pharmaceutical companies, but we actually help pharmaceutical companies understand how well their drugs can be, or how better they can position their drugs in the real world. An example is sort of saying, we can actually identify different adjunctive therapies that patients can take whilst they're on hugely life-shaping treatments. And we can actually improve the lives of patients by analyzing the patient experience on a large scale. So I don't have the answer about how we fully integrate all of this knowledge into the medical system, but I trust that the likes of Ray and whatnot can discuss EHR interoperability, and then we can maybe focus on some strategies about how we integrate this knowledge in ways in which the clinical side can use it.
Great. Well, thank you very much. I thought those remarks were spot on, and I think that at the heart of it is really the realization that all foreseeable future health reforms will be data-centric. So no matter what you're looking at, whether it's more of a consumer-centric engagement model with higher costs being shifted to patients, that involves a lot more data and transparency for patients. Whatever kind of reform, if it's accountable care, if it's single payer, no matter what type of reform you can envision, we need more and better data in healthcare. So I think a lot of the future in healthcare is going to be about more and better data. So the major initiative on that front in the past several years in the United States has been the HITECH Act, and I think it's had two major planks. One is EHR adoption, and the other is health information exchange, which gets to the issue of interoperability that we're talking about here on this panel. My prediction at the time that the law was passed, and I think it's still essentially true, is that it will be crudely effective as to EHR adoption, but that it seems completely adrift in terms of health information exchange. And I think that now that we're further along, I think we can see that EHR adoption in the United States will be dramatically higher post-HITECH than it was pre-HITECH. It will not be universal. It will not be pretty. I think there will be a lot of organizations that suffer greatly getting from here to there. But I think that broadly speaking, you will see EHR adoption in the United States increase as a result of the HITECH Act. And that's a good thing, because you can't be talking about data unless you have, it's not the only setting in which data is generated. I thought Stephen's point is great about social networks and the amount of data and information that's out there. You spend, if you're lucky, 364 plus days a year outside of a healthcare setting. So obviously, if you're only looking at data from the clinical environment, you're not getting the full picture. But having said that, a lot of the most important and essential information is generated in a clinical setting. We need to get that into an electronic format. So I think that the HITECH Act is going to be crudely effective in that sense. The health information exchange agenda at the federal level has been, frankly, a mess. From the very beginning, it has just been aspirational. It's like the world would be a better place if everybody did it, so please, everybody start doing it. There's never really been a business rationale for it in the United States, because the fee-for-service system just doesn't require health information exchange. You get paid a certain amount to see a patient. If you're tremendously well informed about that patient, you get the same amount. So there's really no incentive to deploy systems that will exchange information in a fee-for-service environment. I think the most important change that's happening, I think there's a couple of things that are now starting to incent the adoption of health information exchange. One is meaningful use, and we can talk a bit about how stage one has gone from very rudimentary health information exchange capabilities to stage two, which has much more robust, and we'll see what the final rule says, but clearly ONC wants stage two to be the stage in which HIE starts happening in a meaningful way. But I think you can get just so far with mandates, and eventually you really have to get at the core incentive structure of the system, and that's accountable care and payment reform. And I think that 2 years ago when my organization started doing events on accountable care and payment reform, people would say, interesting, but it's so far away. It just has no immediate tangible effect on my day job. Whereas starting about 18 months ago to a year ago, that completely evaporated. And now we just, anything we do that's related to payment reform or accountable care, we see huge uptake. And I attribute that to the fact that the smart money in the system has figured out that the upside is no longer in fee-for-service, you don't have to leave fee-for-service anytime in the immediate future, but there's no upside there. And that if you want to have any kind of upside in healthcare as a business proposition, it needs to be by delivering accountable care. So we're seeing a huge kind of mental shift among C-suite executives in healthcare towards this reality of getting paid for no outcomes, no income. And as that sinks in, suddenly the question of why I need health information exchange has stopped being asked. I can't remember in the last 6 or 9 months when a senior healthcare executive has said, now why do I need this stuff? Because people realize that accountable care, as I said, like all other imaginable health reforms, is data-centric. I mean, you've got to understand the total cost of care that your patients are receiving. You've got to understand how your referral networks are operating. If you have patients that are If you have one practice that patients are going to the emergency room far more often, you need to know that. You need to figure out why that is. You need to put correctives in place. If you have one practice that's referring a lot more patients to very high-cost out-of-network specialists, why are they doing that? What's the driver? Get on it, change it. Suddenly, the ability to manage care is more population-based. It's less about, just the direct doctor-patient. That's critical, of course, but because it's no longer fee-for-service, it's about looking at the entire set of interactions your delivery system has with your patients and understanding those drivers and what's making things happen and not. So anyway, I think the future of healthcare is going to be very, very data-centric. I think the meaningful use stage 2 requirements go a long way towards advancing that, but frankly, I think it's the adoption or the sense that payment reform is not something that's just out there in the distant future, but that it's coming and people need to be getting ready for it. We're seeing kind of that driver really move the market on health information exchange. So although I think the HITECH Act on its own has been weakly effective at best, I think that the realization that payment reform is coming is finally making the health information exchange agenda in the country develop an air of reality that it just didn't have, frankly, when it was exhortations to people to just do the right thing in a fee-for-service world. So.
Thanks, Ray. Thanks, Stephen. Just to sort of prime the pump, let me read you three of my favorite quotes on this subject, and maybe we can. I'll ask the panel a question or two. First from Dr. John Halamka, who is a CIO of BIDMC and Federal Standards Czar for Interoperability. In a recent article he wrote, "This is medicine today, a sea of paper and fax machines, information silos, privacy barriers, and unconnected data. And yet we know the public is ready for a better system. According to the 2010 Harris poll, 4 in 5 Americans believe that any doctor treating them should have instant access to their medical records online." My second favorite quote is from Kevin MD's blog of last year. "And the thing that truly baffles me, why are hardware and software companies churning out things like Google Chrome and iPhone and Wikipedia, YouTube, Android phones, the iPad, Gmail, Facebook, and Twitter, but we still have EMR companies that look and act like Windows 95. And the third one, which I really like, is from Dr. Ignacio Valdez, who said, "For decades, doctors had no idea what they wanted, and software developers have given it to them." So, but based on that, I mean, there are people out there in the world. There is a contingent of folks who believe that patients should control their medical record, and they're probably not in the majority. If you look at personal health record adoption, it's still in 1% figures. But there, there is a sense out there that if you knew the provenance of each piece of information, if you could track that through metadata, that the patient is really actually sometimes in a very good place to control the data. And this sort of leads to the idea that maybe we could look at a different model, and I realize that this would be a very long shot at this point, considering how far meaningful use has gotten and the backing of the federal government. But there are people it keeps coming up in conference after conference, that maybe we should be thinking about iTunes-type models for modular applications, and that you snap these things together and they become sort of a platform on which physicians, patients, and the healthcare, especially you think about in the ACO model as we move towards global payments, that the patient becomes more of the center of attention, and the community of providers and resources sort of surrounds this patient, and the patient experience and the success of the outcome becomes primary. And so if you're going to include the patient, then I think we need tools, and that the big iron EHR companies really don't have much of an incentive to move in that direction. And so maybe both of you could maybe comment on that. And what are your thoughts?
So I guess sort of drawing on some of my experience about looking at, frankly, tens of millions of patient records and trying to sort of tell or advise a technical team to sort of say, oh, build algorithms to extract this out of it. I find that, looking at such a large general healthcare data set that you frankly can't achieve as much when you don't focus on specific problems. And to your point about saying, well, actually, rather, what I would like to sort of point out is that I do believe that focusing your sort of needs around diseases has multiple benefits. So I believe we're sort of developing this mantra about the same data, different audience, where you can sort of analyze this one piece of information, become really good at extracting that, whether it's a treatment outcome or whatever it might be, and you can start to engage a patient, a payer, a researcher, all at the same time. And I think there's ways in which we need to sort of cut up these informational problems and try and solve them, and have this kind of goal of saying, well, if we crack this one informational problem, what could we do with that? And who could we engage simultaneously? And I believe that's a scalable way of going about it. I don't know if you have any thoughts on that.
Absolutely. I mean, I think that's exactly right. You have to, you can't try to boil the ocean. And I think that in healthcare, we often have expectations that are completely unrealistic and that we wouldn't have in other industries. So if you think about what is the mental model people have of health information exchange, it's health information or of interoperability in healthcare. It's information being able to go anywhere, anytime, seamlessly and frictionlessly. But what does interoperability look like? Let's take an advanced part of the economy and look what interoperability looks like. Let's say PC manufacturers. The Dell supply chain, highly integrated. The HP supply chain, highly integrated. But they're not cross-integrated. You can't pull somebody out of the Dell supply chain, pop them into the HP supply chain, and expect everything to work just fine. But that's what we're saying healthcare is going to do. It's going to go from 0 to that level of interoperability. To me, that seems completely unrealistic. It's got to be business-driven interoperability. And that's why if you think about accountable care, and if you think about global payments or bundled payments and making your money by identifying areas of opportunity and inefficiency and driving those out of the system, then you can start to say, well, we're not boiling the ocean. We don't want all information. Information doesn't have to go everywhere. Core trading partners need to have high degrees of interoperability. So a hospital and its ambulatory referral network, and maybe the nursing homes at most discharges too. But you don't need to have that level of interoperability with everyone else in the system. That's just an artificially high, I mean, to me that just seems like an unrealistic way of thinking about health information exchange. So I think it's a matter of chunking it up. It's not trying to boil the ocean, and I think accountable care starts to create a framework for thinking about who you want to connect with, and it's a trading partner model, not a everyone wants to connect with everyone model, at least not for quite some time.
And just another point on that, I do feel that at sometimes that privacy and who owns the data is really sort of this industry-driven notion. And that most patients that I've spoken with in my experience are saying, I don't care who owns the data, I care what you do with it. And as long as you do something which benefits, myself, the disease area in general, or pushes research forward, then I don't really care. Now, I think, I can't remember who I was speaking to here that, sort of some people think that Al-Qaeda's watching people's medical records, and, there's always that concern, I guess. But I do believe that most patients can sort of combine together, and they can be motivated to sort of pool their records together. And then you can bring people in to sort of really understand how can we improve outcomes and save money. And I do think that there are ways, and social networks, for example, and the internet in general, is really starting to transcend that industry-driven notion of privacy and protectionism, shall we say.
Thanks. Maybe one last question for Ray. So what about consolidation? I mean, a lot of money has already gone into providing incentives for small practices to adopt electronic medical records. There are more than somewhere between 300 and 800 companies out there. There has to be some consolidation at some point. And as far as the small practices are concerned, and especially as they move into sort of an ACO environment, if they do, it seems like there'd be a lot of ripping and replacing or end-of-life products that are suddenly going to be part of this evolution. Do you have any sense of the
Sure. Well, I think consolidation is inevitable. Mickey Tripathi apparently, you mentioned, was here and talked about how 65% of encounters are in organizations of 4 or fewer. I've seen another slide that Mickey does that shows median organizational size in different industries across the United States. So, the automotive industry, the average, the average employee base is, measured in the hundreds, and you keep going down the scale. And the second from the bottom is florists with an average of 3.1 employees, and right below that, at the very bottom, is doctors' offices with 3. So it's, when you're talking about a median practice size of 3 employees, which is the median practice size in Massachusetts, notwithstanding, the partners and children's of the world that we tend to think about, how do you do advanced technology? How do you do advanced analytics? How do you do decision support and all those things? So I think consolidation is inevitable and desirable. How it happens, I think, is, that's still not completely clear. I think accountable care provides one way of thinking about it and kind of a rationale for doing it. I find IPAs, independent practice associations, a very interesting idea because physicians value their independence greatly. And I wouldn't be surprised if, IPAs have been an aggregation play for a number of years around things like contracting and some types of services. I could imagine IPAs, and there are several in Massachusetts that do very nice jobs of providing technology services for their doctors. You could see that type of a model emerging where doctors maintain some degree of independence, some degree of ownership, but also the benefits of aggregation. And so I think consolidation is unavoidable and desirable. Exactly how it happens remains to be seen, but I think something like IPAs and more employed physicians is likely.
Thank you. Any questions from the audience? Anybody have any questions for the panel? It's your chance. No?
Is it just me, or does everyone's living room look like this?
This is a great venue. I love this place. Well, in that case, thank you very much for your attention, and thanks to Ray and Stephen. And we'll, I think, get closer back to on schedule now, maybe.
Thank you.